Thank you, Geronimas. Hello, everybody. I'm Theo Panoskaltsis from Athens, Greece. A warm welcome to you. I'm going to talk to you about a controversial topic, and we're going to go together through some major issues concerning the use of hormone replacement therapy in survivors of gynecological cancer. And of course, we have more and more young patients, premenopausal patients, that they undergo iatrogenic menopause, and we have to face not only techniques for surviving these patients from their cancer, but also to treat problems that we have caused by this iatrogenic castration. Of course, we have to consider vasomotor symptoms, mood swings, and very importantly, sexual dysfunction, which accompanies not only surgery, but also mainly brachytherapy and also chemotherapy induced vaginal atrophy. These symptoms go together with urogenital symptoms, and of course we have to consider the psychological aspects of the sexual, mainly dysfunction, which have to do with the body self-image and the libido. Except for this, we have also to consider the general benefits of hormone replacement therapy, especially in premenopausal women below the age of 50, bone density, cardiovascular risk, and the general benefit of lowering the bowel cancer frequency in these survivors. I would like to focus on the sexuality, which is a major morbidity following any kind of treatment, surgical, radiotherapy, and chemotherapy treatment, and the effect of estrogens, which play a major role in the sexuality of these women. So it's not only the direct effect, but also the indirect effects through vasomotor, sleep disturbances, and all these have to be taken into account. Of course, we would say that general concerns about prescribing hormone replacement therapy in a younger than 50-year-old women would be the general concerns for any women regarding their medical history in terms of their risk, personal risk for developing deep venous thrombosis, strokes, and of course this has to be taken into consideration before even considering the effects that the cancer itself may have on hormone replacement therapy. So let me just give you a case report which we often encounter in our clinical practice, and also go with you through the misunderstandings that perhaps may be related with managing these patients. We have a young 40-year-old leprous patient who has been operated for a ovarian suspicious mass, and we also know from her history that her mother's sister died at the age of 45 of breast cancer. So this woman had a laparoscopic removal of a cyst which was ruptured during laparoscopy, and the final histology showed that this was a micropapillary serous borderline tumor. So we have a 39-year-old nulliparous patient with a micropapillary serous borderline tumor. Bypass for a minute the lecture on HRT and talk about this important issue, because it's a relatively unknown entity to many clinicians, we have to pay credit to Panoskaltsis because he was the first to clarify that these borderline tumors were not equal to true ovarian invasive carcinomas. And if we talk about the histopathological features of these tumors, of course, we have all these cancers exhibits with high cellular proliferation, but on the other hand, these tumors are characterized by relatively low atypia and, of course, no stromal invasion. So it's the stromal invasion which was different. And mostly these tumors are exophytic, but they can also, like this one in the picture, but they can also be found only inside the ovarian. So this neoplasm should be well known to all of us because they may interfere with parity because they are mostly found in younger patients, but on the other hand, they have very good prognosis in general, and they are diagnosed at an earlier stage compared to true ovarian cancer. And also we have to remember a major distinction of the pathogenesis of ovarian cancer, which is the theory prevailing nowadays as it is outlined by the guru of pathologic anatomy in our days, Dr. Kerman, which is the head of the histopathology department in Johns Hopkins in Baltimore. Kerman basically says that there are two pathways of developing ovarian cancer. On the top, you see a gradual transformation of a benign cystadenoma into a borderline tumor, which may give rise to a low-grade, well-differentiated carcinoma. And we have another pathway of inclusion cysts inside the ovary, which may give rise to the higher frequency, high-grade, very aggressive carcinomas. And the high-grade aggressive carcinomas, Kerman says that they are basically born, let's say, inside the fimbria, the tubal epithelium. These plastic cells may be harboring inside these structures of epithelial structures of the salpinges, and with ovulation, these deposits of these plastic cells may be implanted inside the ovary, and this may give rise to a high-grade serous carcinoma. So I'm repeating, this is the prevailing theory at the moment, and which has lots of repercussions also regarding preventing ovarian cancer, but this has to be differentiated from the other pathway, from relatively more benign tumors like the borderline tumors, as I told you before. And the borderline tumors, they are characterized, as I told you, being presented the majority of cases at a younger age, and also they have, generally speaking, a good prognosis. As you see, most of them, they present in stage 1, and also the 5-year survival of stage 1 borderline tumors is excellent, over 95%. However, you have to always keep in your mind that there is a risk of recurrence, which is approximately 10 to 15%, and a later presentation with true cancer of about 3%. These are retrospective data, and year by year we understand more about the pathophysiology of these tumors. For example, as in our case, we may find micropapillary changes or even foci of microinversion, and that raises the question whether you cooperate with a very good pathologist specifically trained in gynecological cancer, because certain cases may be difficult to differentiate from truly invasive cancer, which plays a major role in making decisions about these patients. We specifically look for implants which in the peritoneal cavity, on the peritoneum, and these implants may exhibit this typical known invasive basic membrane changes, but also we have to, like this one, where there's no breach of the basic membrane, but also we have to look for invasive peritoneal implants which are identified with a much worse prognosis. And I raise again the question whether we work with a very good pathologist being able to differentiate between this kind of invasive implants, which will immediately upgrade the final diagnosis basically to that of a truly invasive cancer, and this has to also do with the further management of the patients. In our case, we had a badly treated patient who basically had only a cyst removal and nothing else. This was done laparoscopically. Of course, with laparoscopy, you can very well treat these patients, but obviously it's unacceptable to rupture the cyst during removal, which will increase, as you know, the risk of recurrence. And also there was no staging of this tumor at all. We have to remember that only removing the cyst and not the adnexum of a borderline tumor increases the risk of recurrence. And also we should know that the standard treatment of these patients is to do everything you have to do as in ovarian cancer, except perhaps for the lymphadenectomy. And also you have to look specifically, I repeat, for invasive implants, which will upgrade the diagnosis to that really of an invasive cancer. If you have a young patient who is nulliparous, you can spare the other ovary and the uterus as long as you have a limited disease inside one ovary. So these patients, we can say she didn't have the right operation. But anyway, let's forget about this case and let's talk about prescribing HRT in borderline ovarian tumors. Generally speaking, we can say that there is a major concern with prescribing hormone replacement therapy in borderline ovarian tumors because they are well differentiated in the majority tumors, which means that they exhibit a high expression of both estrogen and progesterone receptors. So in theory, HRT should be avoided after iatrogenic menopause in young patients with complete pelvic clearance with borderline tumors. The second point is whether you should look for any genetic predisposition for this lady to develop this tumor, remembering that her aunt died at the age of 45 because of metastatic breast cancer. So would you say that based on her history, would she have any high chances of testing positive for a BRCA mutation? The answer is she doesn't have a very high chance. She only has one relative, and not first degree, a second degree relative, which makes her probably be at risk of carrying a BRCA mutation of about 10%, up to 10%, let's say. And here is something to remember. If you have only one case, the risk is probably 1 in 10. If you have 2 cases below the age of 60, the risk of just simply by taking the history of saying that she carries a BRCA mutation is about 20 to 30%. And if there are many cases, more than 4 cases at the young age, the risk is very high, over 50%. This could be used as a guidance, as a clinical guidance, if you like. And if we go to the principles of BRCA, we have a solid knowledge that approximately 10% of breast and ovarian cancers are caused by mutations, and 65% of these mutations, or even more, are caused by BRCA1 and BRCA2 inactivation genes. So going back to the theory of Kerman, we would say that this lady has a very low probability or even no probability of being related to any genetic alteration, because the pathway of developing her borderline tumor is the other way, not the typical high-grade ovarian carcinoma, which is mostly associated with BRCA mutations. We know where to look for BRCA mutations in the human genome. We know we have identified the location of BRCA1 and 2, and I would like to point to you, when you deal with these patients, that although common knowledge says that BRCA mutations are found mostly in high-grade serous adenocarcinomas of the ovary, there are certain studies, and there may be more to come in the future, which show inactivation of BRCA even with borderline cases. So in general, we could say that borderline ovarian tumors do not predispose to a higher chance of carrying a BRCA mutation. However, our knowledge is still limited on the subject. There may be even more subtypes of genetic alterations in the future to come, which may elucidate further our knowledge on this subject. And it's very important knowledge, because we know that these mutations, they are inherited through the autosomal dominant characteristics, and which is very important because it may affect both men and women being carriers of these genetic mutations. Here you see a typical genetic tree of no missing a single generation of alteration of breast and ovarian cancer, which mostly indicates perhaps a BRCA1 mutation, and all of them are less than 55-year-old. And also this Antoniou, this Greek Cypriot, Oxford-based epidemiologist and molecular biologist, has identified as the lifelong risk of developing breast cancer with a BRCA mutation being about 65%, and 40% for ovarian cancer, the lifelong risk of people carrying BRCA1 mutations. The BRCA2 risk of lifelong risk of developing breast cancer is less, but remains very high at about approximately 45%, and the risk of developing ovarian cancer, it's 10 times more the general population risk, about 11%. So that's why we advise prophylactic surgery in BRCA documented carriers to avoid the development of ovarian cancer after they have completed their family. But also because prophylactic ovarectomy not only reduces ovarian cancer almost by 100%, except for the primary peritoneal cancer, but also because we know that prophylactic oophorectomy may reduce the risk of breast cancer in these BRCA carriers by 50%. And this is a knowledge that has been known to us by this major EBEC study for more than 15 years ago. The question is, can we prescribe HRT in breast cancer in BRCA carriers, whether it's a documented metallaxis or whether we suspect strongly that there may be a genetic predisposition according to their family history? So it's an open question, but in general we can say that in women who are BRCA carriers, we can safely prescribe hormone replacement therapy. And we can say that from many reviews and meta-analysis, which are based, though not in big numbers, but none of these small studies has identified a high risk of developing breast or ovarian cancer, mostly breast cancer in women who have hormone replacement therapy and who are, I repeat, BRCA carriers. So in general, we can say BRCA carriers can be safely prescribed HRT, and most data would suggest that unopposed estrogens, as long as they have their uterus removed, they probably are safer than combined estrogen progesterone HRT. Now coming to the real danger, the real killer, the epithelial serous ovarian cancer, is a completely different story. We know it's a serious killer because it presents at an advanced stage, being very deep inside the abdomen. There's no screening method for ovarian cancer. It gives very unspecific symptoms at the beginning of the development of the disease. And also, on the other hand, we know that 1 in 5 women diagnosed with ovarian cancer will be diagnosed at a premenopausal age. So even if we have to face a deadly disease, we have to take into consideration quality of life, which may be as important as recurrence in these patients. Generally speaking, also along the concerns of borderline ovarian tumors, there is some hesitancy, let's say, that the well-differentiated serous ovarian cancer may be a contraindication to prescribing HRT because these tumors, the well-differentiated tumors, have a high percentage of ER expression. Therefore, we may trigger a recurrence if we give hormone replacement therapy, even just unopposed estrogens in these women. Having said that, if we look carefully at the meta-analysis, which now they become more often visible on the PubMed, we don't see any increased risk of recurrence in patients with ovarian cancer who have been given hormone replacement therapy. So, although there's a theoretical concern that there may be a triggered reaction with estrogens regarding the risk of recurrence, this is not substantiated by data from non-randomized studies, retrospective mostly studies. On the contrary, as you see here, patients that may even do better with hormone replacement therapy. So generally speaking, we could say that contraindications to prescribe hormone replacement therapy in ovarian cancer survivors refers only to their medical history and to their risk of strokes or deep venous thrombosis rather than the histological diagnosis per se of the ovarian cancer. Now, talking about endometrial cancer, also here we have the problem that most of the endometrial cancers are well differentiated endometrioid adenocarcinomas, and therefore we expect most of the patients with endometrial cancer to have tumors with high expression of both estrogen and progesterone receptors, or even co-expression in the majority of cases. So in theory, we could say that HRT should also be avoided in the vast majority of these patients. Again, data are very scarce with HRT in endometrial cancer, and if you look at studies in the past, there are very few non-randomized retrospective studies, and also women with endometrial cancer were given in the past not only unopposed estrogens, but because there was uncertainty about the risk of breast, they were given both estrogen and progesterone in some small series. However, there's no indication that giving HRT, even the combined HRT, increases the risk of endometrial cancer, of recurrence of endometrial cancer in these patients. And we have also recent meta-analysis like this one from Korea, where you see if you put this limited, I repeat, data together, there's no increased risk of recurrence of endometrial cancer with the use of hormone replacement therapy. So again, as it happens with ovarian cancer in general, although there's a theoretical concern of triggering ER-positive tumors recurrences, this is not substantiated by this limited availability of data we have from these small retrospective studies. And any contraindication should mostly be based on personal risk factors referring to their medical general conditions. One firm exception to this should be the uterine sarcoma, because most of the uterine sarcomas express heavily both ER and PR receptors, and also, as it is outlined even in the recent guidelines, we have to look, ask the pathologist to look specifically for expression of ER-PR receptors, because anti-hormone treatment, anti-estrogen mostly treatment, may be used in order to manipulate, to give adjuvant therapy or even treat recurrences, which may abundantly be seen through the hematogenous route in this kind of patients. As you know, uterine sarcomas are lethal in the majority of cases. There is uncertainty about the use of chemotherapy and radiotherapy, and recent guidelines have highlighted the importance, perhaps, of hormonal manipulation as adjuvant therapy in these patients. So we would say that uterine sarcomas in general should be a contraindication to prescribing either only estrogen or combined HRT. So if let's say you prescribe hormone replacement therapy in an ovarian endometrial cancer survivor, except for the risk from their own disease, what would the breast cancer risk be? This is a major question, and we don't have the time in this seminar to go in detail through the available publications. However, we can say that official recommendations of national societies like this one from the National Institute for Health and Care Excellence in the UK regarding managing the menopause, there is a clear statement that HRT with estrogen alone is associated with little or no change in the risk of breast cancer. And HRT with estrogen and progesterone may be associated with an increase in the risk of breast cancer. So we see in recent years there is a shift of prescribing, if you like, in ovarian and endometrial cancer survivors HRT more often, but definitely avoiding the progesterone, because there's more and more evidence that progesterone triggers more breast cancer cases, and therefore unopposed estrogens offer the best chance of giving HRT in these patients. So if you have let's say a 45-year-old woman who has had an iatrogenic menopause because of ovarian and endometrial cancer, we can say that unopposed estrogens is the most accepted form of hormone replacement therapy at the moment, up to 5 years, up to the reaching the age of natural menopause, and with definitely reassuring the woman that this will not increase her breast cancer risk. I don't know what happens in other countries. In Greece, we favor very much the use of transdermal absorption of estrogens, because we like the theoretical advantage of bypassing the enterohepatic cycles of metabolizing estrogens, and estrogel is a very popular form of prescribing HRT in this kind of women in Greece. Another form of estrogen, which is also becoming very popular, I think is readily available in all European countries, is the intravaginal estriol gel. In Greece we call it Blisel, or as in other countries I think, and this is estriol at 50 micrograms per day, and is a continuous use which is licensed for using up to 3 months, and with the theoretical advantage that estriol in this form is not absorbed heavily in the systematic circulation. We particularly like using Blisel in cases where there is major vaginal atrophy caused by a combination of iatrogenic menopause and atrophy caused by brachytherapy, and we find it extremely helpful with astonishing results in terms of remodeling the vaginal epithelium. So I think if it's true that Blisel is not absorbed in substantial amounts from the circulation, this is a very, very potent weapon we have to treat mostly sexual dysfunction associated with surgery and radiotherapy. But talking about local therapies, I would like to stress that prescribing both regulators of pH like the prolactic acid and also gels that they promote hydration of the vagina, as long as they are used properly and with the right dose and for long periods of time and in a systematic way, they also produce and sustain the results of the hormonal therapy. So if you use Blisel for a month, let's say, or 2, and then you convert to prolactic and replenish gels, but as long as the women use it on a regular basis, the results can be excellent regarding hydration and acidity of the vagina, with excellent results. Talking about sexuality and vasomotor symptoms, there are also many other drugs that they seem to work very well, especially for vasomotor symptoms. In Greece, we very much like SSRIs. Venlafaxine, Effexor, as it is named in many countries, can be used in an increasing dose. We usually start with half a pill per day, 33.5 milligrams, and we may increase the dose up to 75 milligrams per day. And this is an excellent way of controlling vasomotor symptoms, but also making the patients, treating the insomnia of the patients. But we have to stress to the patients two things. The first thing is that in order to see any benefits, they have to take it continuously every day, and they will only start to see benefits after a period of 15 to 20 days. So many patients expect these tablets to work straight away. This is not true. They have to build up concentration in the bloodstream. Cipralex, escitalopramine, is very good treatment also for vasomotor symptoms, and also gabapentin and clonidine, but these are my second choice. My first choice being Effexor, venlafaxine, because I have personally seen a very great response, and there's no withdrawal effects when they stop using the treatment. The American Endocrinological Society also recently, in their bulletin, they have stated that venlafaxine may even better than estradiol for the therapy of anorgasmia, pain, and vaginal dryness. And also, but also we have to remember that certain SSRIs like fluoxetine, Prozac, in other words, and Seroxat should not be used, as they may inhibit the effect of SERM's modulators, mostly tamoxifen. So we have to keep in mind that there may be a counteraction of SSRIs in patients who are taking tamoxifen for breast cancer. So in conclusion, we can say that the iatrogenic menopause risks may outweigh the recurrence risk in many patients with endometrial and ovarian cancer. Certainly, there are no randomized studies, especially in cases of estrogen and progesterone positive tumors with good prognosis. But so far, the data, although are limited, are reassuring that there is no, in general, major concerns to prescribe HRT in these patients. And if there is major concern, or if there is a contraindication other from their medical history, we have non-hormonal valid alternatives that can be used, and they produce also very, very good results, even long term. I would like to thank you very much and I would like to thank EMAS for giving me the opportunity to just outline a few major statements about hormone replacement therapy in gynecological cancer. I would like very much to thank Geronimus for his kind hospitality and being patient with me, and I'm looking forward to any questions if you have any. Thank you very much.
All right, thank you, Doctor. And I guess we have one question. So it's in patient with ovarian, CA post-surgery, and endometriosis. What would be the best HRT option given the risk of reactivation of endometrioid tissue with unopposed estrogen? Would you use progesterone? If so, which one?
The question is if you have an endometrioid cancer of the ovary.
Yes.
And whether we would use a combined or non-combined hormone replacement therapy because of the possible reactivation of endometriosis.
Yes, of endometrial tissue.
First of all, in terms of risk of recurrence, recurrence of endometrioid ovarian cancer, we don't have any data for this subject. This is a valid question, and I would certainly not be afraid as long as it's a ovarian cancer with excellent prognosis to give hormone replacement therapy to this patient. Now, the type of treatment, I would give a combined hormone replacement therapy for the theoretical effect of reactivating endometriotic implants, although I repeat, there's no much evidence in the literature from this. And I would use I would certainly favor the use of transdermal estrogen and combined with oral use of progesterone for a period of not continuous but only for a period of 10 days per month.
Okay, thank you. And we have one more question. What HRT can be used in a patient with a history of endometrial hyperplasia without atypia?
Endometrial hyperplasia is now the WHO has changed the histological diagnosis. So the old histological classification of simple atypia, complex atypia, and complex complex atypia is not valid anymore. The WHO now says that simple atypia is not a precancerous condition, basically. The simple hyperplasia is not a precancerous condition. So because in the past we used to say that it carried 1% risk of cancer, which is mostly the general population risk. If we are talking about complex atypia, which is nowadays we favor the term EIN, endometrial intraepithelial neoplasia. This is a genuinely precancerous condition of the uterus. And we have data mostly coming from Harvard, from the histopathology department of Harvard Medical School, from the Professor Matter, which show that the complex atypical hyperplasia carries a lifelong risk of developing cancer, about 40%. So if you have a patient with complex atypia, complex atypical hyperplasia, you have to have the uterus removed of this patient. You are not allowed to keep the uterus in this patient. And this woman, if she has a hysterectomy when she has completed her family, then she will have unopposed estrogens, of course. And let me also clarify something. that we see many times women being diagnosed with complex atypical hyperplasia, being treated with high doses of progesterones, and then this diagnosis reverts to normal endometrium. I would like to clarify that we only suppress the expression of the hyperplasia at histological diagnosis. At molecular level, there is still the loss of P10, for example, which will, it's an unstable factor and which poses this woman the risk of developing endometrial cancer in the future. So there's no place for conservative management of complex atypical hyperplasia, even with a normal histological diagnosis after treatment, because we only suppress the condition. These women should have a hysterectomy when they complete their family as a definite treatment. And in this case, unopposed estrogens is the right choice, I think.
Okay, thank you. And we have still time for one last question. And the question is ERT suitable for a patient who had surgery and chemotherapy for clear cell ovarian cancer and suffer from severe menopausal symptoms at age of 63?
Again, at the age of 63, first of all, generally speaking, I think it makes sense to use hormone replacement therapy in women who are young, let's say below the age of 50. It doesn't make too much sense to me to use hormone replacement therapy in women over the age of 60, especially with histological tumors that we don't know very well their biological behavior. Clear cell carcinoma is not always as good prognosis as endometrioid carcinoma of the ovary. Usually exhibits very aggressive characteristics, and I would be very hesitant. I would certainly say I would never recommend in a 63-year-old lady with a clear cell carcinoma the use of HRT with estrogens because it's an aggressive tumor, because he's 63, and because there are so many other ways to treat their symptoms. And if the vaginal atrophy it's the problem of this woman, and as long as there's no evidence of disease recurrence, and I would only possibly give her the bliss cell because it's not absorbed in the circulation, and I will only give it for a limited period of time, let's say 1 to 2 months maximum, and then convert to lactic acid modulators and to hydrating creams. In general, I would avoid HRT over the age of 60 with such aggressive histology.
Okay, so our time is up, but we still have one last question, and could you answer it shortly? What would be your personal position about treating the vasomotor syndrome of a patient with hormone-dependent breast cancer, but already in complete remission after finishing treatment?
I didn't get the question. Vasomotor symptoms?
Yeah, I can repeat it shortly. What would be your personal position about treating the vasomotor syndrome of a patient with hormone-dependent breast cancer, but already in complete remission after finishing treatment?
I would certainly use venlafaxine. I would use SSRIs. SSRIs in clinical trials have shown that they are equally effective in treating vasomotor symptoms as much as estrogens. So I would give venlafaxine for this patient, FXR. I would start at half the dose per day, 33.5 milligrams per day, and I would gradually increase it up to 75 milligrams per day. In my practice, this venlafaxine can make wonders. It's a very good drug as long as, I repeat, it's taken every day and at the same time during the day, and also patients knowing that the effects of the medication will only be realized after 15 days to 20 days after taking the drug. SSRIs is my first choice in these patients.
All right, thank you so much, and just conclude the presentation and the webinar. Thank you so much for a wonderful presentation, Professor, and
Thank
all the
you.
attendees for being here today. Just a quick reminder, you will receive a brief survey that pop up when I end the webinar, and we appreciate your response. Thank you, everyone, and have a great rest of the day. Thank you.
Thank you. Thank you. Thank you. Thank you.